DISCIPULUS was the steering project to guide the program for development of the virtual physiological human. The things that are needed to bring it to reality are a mix of ingenuity, collaboration between different disciplines, and very significantly sufficient funding to drive the development of these models. I think, like most people, I want the digital patient to be many things. As a GP, I want the digital patient to help me evaluate different treatment strategies with an individual patient. I want the digital patient to act as an aid to communicating risk or the consequences of different choices, whether they're therapeutic or whether they're lifestyle choices. But there are all sorts of other things that the digital patient could be. It can be used for helping to develop strategy at a higher level, at a district, regional level, or even as part of the development of guidelines. The pharmaceuticals industry would want the digital patient to be a tool they can use to evaluate potential new drugs and treatments and guide them in the development of drug trials. The data that's necessary for the digital patient to work and to be functional will include basic statistics, mortality rates, prevalences of diseases, distributions of risk factors in a population, but also data about individuals. And the data required might vary according to the particular use case. If you have a patient with you in a consultation, that's easily obtainable. But if you're wanting to analyse risks across a district, for example, you'll need to access data from the record, the patient's clinical record. The digital patient is likely to be more than one thing, I think. I don't think there will be one digital patient that will cover all potential use cases. For use in the consultation with a patient, there will need to be particular visualizations in interfaces with the models. And of course those would have to be developed specifically for that person. But once a core model is developed, then that's easily achievable. In the consultation, I would expect to have visualizations of the digital patient that are built especially for that use. And I would expect that to have access to that particular patient's records, so it would have to access either the clinical system or some portal into the clinical system to get access to their baseline data. And it would also need to be able to present the results of the analysis in ways that not just clinicians understand. Well, it needs to present information that is useful to clinicians and is useful and interpretable by patients, and doctors and patients will have different perspectives on what they want to get out of that system, and the digital patient visualization in that context will need to service those different requirements. In general practice, the likely circumstances where you'd be accessing this is not highly mobile. This is in contrast to hospital applications, for example, where mobility is very important. In general practice, you'll be doing analysis either across your practice population on a desktop, or you will be in a consultation room with the patient, or you will be at the patient's home. So the mobility only needs to be as far as taking a laptop into a patient's home, for example. Accessing it via the iPhone or a mobile phone or a smartphone will be less critical, I think, in that context. Maybe very different in other specialities. The benefits that I would expect to get from the digital patient are at two levels. Firstly, the digital patient will, in advance or quite separately from an interaction with an individual patient, enable optimal management strategies for particular situations to be worked out. So I can have greater confidence that when I have a number of treatment choices to make, that I will be choosing an optimal one for a patient in that situation. The other benefit is with the patient there and doing an analysis of a particular circumstance in a particular patient with a number of choices, and I would expect that to increase my confidence and reduce my uncertainty in making these choices, and not just in terms of optimizing the outcomes from the perspective of the doctor, i.e. perhaps a reduced blood pressure, better control of pain or whatever, but I may also have increased confidence that the choices that are made will better match the patient's perspective. What I see as the most positive outcomes are not necessarily what the patient sees as the most positive outcomes, and the digital patient can act as a tool to support that shared decision-making process. The digital patient needs to be workable at the GP level. For example, where the digital patient is being used for risk communication, the use of the model needs to be easy, intuitive, fast, and the results need to be represented in a fashion that is both relevant and intuitive to understand for both the clinician and the patient. This probably means having a variety of outputs to suit different audiences. One example of a use case would be evaluating the benefits of taking aspirin in an individual patient. Aspirin can reduce the risk of cardiovascular disease, heart attack, stroke. It can reduce the risk of cancer, both bowel cancers and other cancers, like lung cancer, for example. However, aspirin also increases the risk of peptic ulceration and hemorrhagic stroke and abnormal bleeding. Now, the risks for each of those problems may vary from individual to individual, and it's possible that taking aspirin for some individuals reduces their overall risk and in others increases it. And it's very difficult to, in any individual case, to work out which that would be. The virtual physiological human, the digital patient, could make that much easier to do on an individual basis and help patients come to a decision as to whether that's something they could benefit from. In terms of evaluating the digital patient, this is obviously very important. The clinicians and the patients that use it need to have confidence that in the veracity of the results that are being presented to them. And the evaluation needs to take into account things like the transportability of the models, how it performs in different populations. You may have a model built and fitted to one population that may not be very predictive or perform very well in another. So there would need to be some confidence about how the digital patient performs in different contexts. There is also the issue of what might be referred to as spectrum transportability, or the performance of the model in extreme cases. In medicine, almost by definition, you're not dealing with people in normal situations. There's going to be something abnormal there in most instances, and the model needs to perform well on average and in the average, but it also needs to perform well in the extremes, at the highest blood pressures, at the lowest blood pressures, and in the most extreme of circumstances, to be useful clinically. The big stumbling blocks are perhaps threefold. Firstly is data. Models need data to work. They need data to be developed and fitted. They need data to be parameterized to a particular situation. They need access to the data of the patient's data, and that obviously raises questions about accessing the clinical systems and how that's done in a safe way. So there is a challenge around confidentiality as well as access to the data. Secondly, the confidence in the users needs to be established for it to be used. You may be able to develop a very effective digital patient, but the adoption may be another task that needs to be overcome. And that's notoriously difficult with technological innovations in medicine in particular. The third issue is around usability, and in medicine is by definition a very responsive profession. It's almost always acting in response to demands from patients who are unwell and their states are changing. This means that medicine is often very unplanned in the way it unfolds in the workflow of individual clinicians. The average GP, when he turns up to work, has no idea what the day holds for him, or even what the first patient holds for him. And this can create time pressures and complexities in the workflow that mean any innovation has to fit smoothly, integrate smoothly into the workflow of the users. And if it doesn't, it won't be used. And if it requires technical knowledge and prowess, it will be a barrier to adoption. So making sure staff are sufficiently trained in the use of computers and computer technology to make that easy will be crucial to its adoption. The challenges they will face will be firstly in investment. To build these models are very complex, and not only very complex, but quite rightly the standards of functionality are very high. You have to be able to demonstrate their veracity very thoroughly before it would be acceptable for them to be used, and that takes investment, time, and money. Secondly, access to data, and that can be access to the data for parameterizing the models. We may have the digital patient, but to then translate that to a particular context, you may need to reparameterize for a particular country, or a particular part of a country, or a particular population within that country, and access to the data needs to be there. Access to freedom of access to the model itself and its code is probably critical. If the digital patient, if the virtual physiological human project results in many examples of very good models with closed source code, it's likely to fail in its objective of delivering clinical benefit in medicine, because it becomes so difficult for innovators and companies to implement. So accessibility of code, openness of code is quite important. Having adequate support, training, manuals to ensure efficient and effective use of the models is also important. The research at this point probably needs to focus more closely on two things. Firstly, connecting the development of specific models with specific use cases. So, actually examining how models like this would be used in general practice or in hospital context or in a public health surveillance unit, for example. The other important area of research would be exploring not just how to develop different kinds of models, but how different kinds of models need to interact and communicate and talk to each other, what combinations of modelling are appropriate and what are not. The virtual physiological human won't be a model. It will be many models, and different models perhaps under different circumstances. So having a framework that allows these models to be integrated and switched around and modified and updated without resulting in a complete rewrite of the model, the virtual physiological human would be vital. Otherwise, it will be very good for a very short period of time in a very particular circumstance. It's quite possible that one thread of the virtual physiological human would be some kind of three-dimensional representation of an individual, and not only three-dimensional, but three-dimensional augmented, for example, by their individual genetic code, physiological parameters, and that I would see as a natural extension of the virtual physiological human, and that would have uses, for example, in training, particularly anatomy, things like that. But it is, in terms of general practice, is not likely to be something that would be feature very highly in a consultation. Usually, a consultation will be very focused around a particular problem. There may be a role for 3D visualizations of an individual to assist doctor-patient communication. If you have a 3D virtual image of a patient and you can help visualize a structural problem for them, that can greatly facilitate communication. There may be another role in terms of communicating risk by forward projecting 3D representations. So, for example, with risk factors for atherosclerotic disease like smoking, obesity, it may be possible to forward project a three-dimensional image of that patient's coronary arteries, for example, illustrating the formation of atheroma under different conditions, with them smoking and with them not smoking, for example. DISCIPULUS has identified a number of key hurdles that need to be overcome to achieve the objectives of the digital patient. Probably one of the biggest hurdles is obtaining relevant data and ensuring the quality of that data and having standardized common understandings of what the data represents. The virtual physiological human will involve a considerable amount of multidisciplinary and teamwork. There will need to be models from a variety of disciplines: clinical, physiological, engineering, fluid mechanics, and all of these different disciplines need to be able to find some common standardized understanding of how they will fit and work together.